Our guest today is Dr. Kathleen Martin Ginis, who is a friend for many years. Kathleen is the Reichwald Family UBC Southern Medical Program Distinguished Chair in Preventative Medicine. She is a Distinguished University Scholar at UBC, and she's also the Center Director in Chronic Disease Prevention and Management. Beyond that, there are other titles, but we have limited time. At the very least, for a number of years, Kathleen has been a principal investigator at ICORD, where she affiliates with their group and also runs her trials. Kathleen is a tour de force of a degree in kinesiology and psychology, 325 peer review publications, dozens of the most important clinical guidelines that we use were chaired by Kathleen, and just short of 27,000 citations of her work in the literature. So she's busy, and when Kathleen talks, people listen. So it's a pleasure to welcome her here to talk about an area that's important to all of us, and that's the motivation of people to exercise when they have a disability. So it's a pleasure to welcome Dr. Kathleen Martin Ginis.
That was such a kind introduction, Mark. Thank you very much. And I have to admit, I'm up here, I'm having a bit of a career bucket list moment. I started doing work in spinal cord injury about a little over 20 years ago. And as you heard, my background's not in physiology. I don't have a medical degree, but my background is in psychology and behavioral science. And when I got into this area, I was really interested in physical activity behavior change, exercise behavior change for people with spinal cord injury. And I remember going over to the library, because that's what we did back then. We actually went to the library and trying to find research on physical activity behavior and spinal cord injury. And there was literally nothing. But I do remember coming across the work of Dr. Gator and Dr. Nash. And over the years, in the frustrating times of trying to change physical activity, of seeing the amazing work that was coming out of the Miami project and seeing the tremendous benefits of exercise participation for people with spinal cord injury on health and well-being. And just really want to acknowledge the legacy of Dr. Gator and Dr. Nash's work that's really inspired me to keep going over the years, knowing the benefits of physical activity and trying to find ways to improve physical activity for people with spinal cord injury. So just a bit of background. I'm born and raised in Toronto, which is a straight shot. If you get in your car and drive for 20 hours, as many Canadians do, you can be in Toronto. And I worked at McMaster University for 17 and a half years. And then 6.5 years ago, I moved to the University of British Columbia, which many of you might know as being the home of ICORD. What you may not know is that while ICORD is in Vancouver, UBC has a second campus in Kelowna, which is about 300 miles east of Vancouver, nestled in in a valley within the mountains. And it's spectacular. We are a city on a lake, nestled in the mountains. We're known for our amazing wines. We've got some great beaches, not quite Florida beaches, but some fantastic beaches, and the winters aren't that bad either. And this is our campus, and I do want to acknowledge that our campus is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan peoples. So I have 3 objectives with my talk today. First, I'm going to set the stage for talking about physical activity behavior change by giving a bit of an overview of research on physical activity for people living with SCI and other disabilities. I'll then move on to sharing some evidence-based best practices to support people with SCI to become more physically active, and finish up with some calls to action. So to set the stage, I'm going to be sharing research that we presented in the Lancet Physical Activity Series in 2021. So every Olympic quadrennial, or at least the last 3 quadrennials, the Lancet has featured a series of papers specifically on physical activity. And I was very honored to lead the first Lancet Physical Activity Series paper on disability. And I do want to acknowledge my many international co-authors on this paper. So in that paper, we had 4 key takeaways. The first is that looking across 36 meta-analyses of physical activity interventions involving people living with disabilities, it's quite clear that physical activity is associated with improved fitness, mental health, and cognitive function. The data for cardiometabolic outcomes wasn't all positive, but there were still, for the most part, data showing significant positive effects. Looking specifically at research involving people living with spinal cord injury, over the past 20 years, significant research has accumulated showing the significant physical, psychological, social, and even economic benefits of physical activity for people with SCI. Now, in both the general disability research and the SCI specific research, there are some important caveats to the existing body of research. Unlike in the general population, for whom we have reams and reams of studies showing the effects of exercise on all-cause mortality and specific chronic disease, there are virtually no studies of the effects of physical activity on the risk for all-cause mortality and chronic conditions such as site-specific cancers, cardiometabolic disease. The other important thing to point out is that most of the studies in the meta-analyses prescribed exercise that's less than 150 minutes per week, which are the World Health Organization guidelines. So on the plus side, what these data are suggesting is that we can see significant benefits of physical activity prescribed below the WHO's threshold. So keep that in mind. I'll come back to that idea. But the flip side is I think this is probably why we aren't seeing consistent benefits for the cardiometabolic outcomes. I think the exercise probably needs to be a little bit more intense and for longer duration than what most of these studies prescribed. The second takeaway from the Lancet paper was that children, youth, and adults with disabilities are 16 to 62% less likely to meet physical activity guidelines compared to people without disabilities. And people look at that statistic and they're always like, 16 to 62%, couldn't you have got that a bit more specific? But the reality is, again, in the general population, we have tremendous databases internationally with physical activity data. For people with disabilities, these 7 lines of data are pretty much all we've got. One of the reasons why we have so few data is that having a disability is often an exclusion criteria for participating in these large-scale national and international surveys on physical activity, or disability isn't measured, and if it is, the data aren't disaggregated to present the data specifically for people with disabilities. The other problem is that different studies use different measures of physical activity, which aren't always validated for people with disabilities, and different measures of disability itself. All this together makes for very imprecise measures and estimates. With regard to people living with spinal cord injury, we know that people with SCI are at the lowest end of the physical activity spectrum. So these data come from my colleague Rita Vandenberg-Emens from the Netherlands, and she measured physical activity using both accelerometry and also asking people's physicians how much activity they think they do in people with a wide range of chronic conditions. And she's lined them up here from most active on the left to least active on the right. And this blue bar is an able-bodied reference category group. And we see that way down here at the right, we see people living with spinal cord injury and people with congenital spinal cord impairments. And we see that they're at the lowest end of the physical activity spectrum, doing about 1/3 the amount of activity of the general population and less than all other groups. With regards to epidemiological data, work that I did in Canada, collected data from 700 people living with spinal cord injury. In our Canadian data set and most of the available international data sets, we see that about 50% of people with spinal cord injury do not participate in any sport or exercise whatsoever. And I emphasize sport and exercise as opposed to physical activity in general, because at this point, based on the evidence, sport and exercise participation is the only type of physical activity that we've seen linked with fitness and health benefits. Another key takeaway from the paper is that children, youth, and adults with disabilities face extensive barriers to physical activity participation. So this was based, we've done 2 meta-syntheses now of almost 25 review articles, reviews of papers that have looked at barriers and facilitators to physical activity. And of those 25 or so papers, at least a dozen of them focus specifically on people with spinal cord injury. So I think right there, a key takeaway is we don't need any more studies looking at barriers and facilitators to physical activity in people with spinal cord injury, at least not in high-income countries. We know what they are. Rather, we need efforts to try and alleviate and address those barriers. And when we line them up in a social ecological model, what we see is that these barriers exist at all levels for people with disabilities within ourselves, such as psychological factors, body functions and structures, but also interpersonal or social environments, and at institutional, community, and policy levels. This, I think, begs for interventions that address barriers at all of those levels. But to date, virtually all of the physical activity intervention research has focused on changing factors within the person and also factors within their social environment. Now, the good news is that looking at those interventions, targeting those interpersonal and interpersonal level factors, the evidence is quite clear that these interventions can increase physical activity in people with physical disabilities. So across 7 meta-analyses, we found the median effect size was 0.64. So that's in the medium to large range, suggesting positive effects of interventions on physical activity levels. Looking specifically at physical activity interventions involving people with spinal cord injury, again, a decent effect size, 0.54, which puts the effect in the medium-sized range. So with that as a bit of a backdrop, I think we do have sufficient evidence to begin formulating and using some best practices for designing and implementing physical activity behavior change interventions, specifically for people living with spinal cord injuries. And that's what I'd like to share with you now. So when thinking about best practices, the first key question is what should be included in these intervention packages or in our intervention delivery? A few years ago, Tony Williams, who's an outstanding qualitative researcher, and my qualitative methods are still developing to be even generous, I think. Tony came across to our lab and she helped us do a qualitative metasynthesis of qualitative research in which people who had mobility impairments who had participated in a physical activity intervention were specifically asked, what was it about this intervention that helped you? What did you like about it? And what we tried to glean from pulling together all that qualitative research was the key ingredients or the secret sauce in physical activity enhancing interventions. So from this metasynthesis, we found 3 key themes. So first of all, participants said that the effective interventions provided them with evidence-based information on physical activity and how to self-manage their impairment or their condition. And we know from a physical activity standpoint that people with disabilities want lots of different types of information on how to be active. For a person with a spinal cord injury, there's often a lot of anxiety about becoming active again. People aren't sure what to do, how intensely. I've heard too many stories of people with spinal cord injury going to a gym or a fitness center and being turned away because the people there just don't know what to do with them. So given these barriers, I think this is where disability or SCI specific physical activity guidelines can be particularly helpful. In 2020, the World Health Organization relaunched their physical activity guidelines. And in that relaunch, they issued guidelines for people living with disabilities. Those guidelines were essentially a rebranding of the physical activity guidelines for the general population. So what the WHO said was that the guidelines that apply to children, youth, and adults without disabilities can also be applied to people living with disabilities. What this means practically is that the WHO in their new guidelines say that adults should achieve 150 to 300 minutes per week of moderate to vigorous intensity physical activity for health benefits. And they've taken those guidelines and applied those to people with all types of disabilities. So I have a bit of a problem with this. And I've written quite a bit on this issue. And my first and primary concern with extrapolating the WHO guidelines to people with disabilities is that those WHO guidelines are based almost entirely on studies of people without disabilities. There was virtually no studies of people with disabilities included in the evidence base to formulate those guidelines. That means that the guidelines don't account for physiological differences, I think particularly about people living with spinal cord injury and differences in the physiological responses to exercise, and especially for people with tetraplegia. They also don't account for the contextual differences, that the barriers that people with disabilities face to physical activity are so plentiful and so different to what the general population face, that these guidelines really do need to take that into consideration. My third issue is that the safety of the guidelines is unknown. I can't find a single study involving people with disabilities that has looked at the long-term effects and outcomes of exercising for 150 to 300 minutes per week. So all that really concerns me. And as a result, I've been a strong advocate for developing disability-specific guidelines, and in particular, spinal cord injury-specific guidelines. So back in 2011, I worked with a Canadian group to develop Canadian physical activity guidelines for people with spinal cord injury. In 2016, I pulled together an international team along with Vicky Gusi-Tolfree. So we had scientists, Jim Rimmer represented us from the US. We had scientists from all across Europe, from Australia. We've since worked with scientists in various Asian countries to develop scientific exercise guidelines specifically for people with spinal cord injury. The process we use to develop these essentially follows the WHO best practices for developing guidelines, but our systematic review consisted exclusively of studies involving people living with spinal cord injury. We pulled together every study we could find of the effects of exercise training on cardiometabolic health and fitness outcomes in people living with SCI. From those 211 relevant studies, we synthesized the evidence. We presented it in recommendations with the key findings from that body of evidence. And then we presented it to 3 different international panels. And those panels consisted of scientists, people living with spinal cord injury, representatives of community organizations, physiotherapists, rec therapists, occupational therapists, who all reviewed the evidence and then formulated guidelines. From those deliberations came 2 scientific guidelines. The first is essentially a reaffirmation of the Canadian guideline we developed in 2011. And what that guideline states is that for cardiorespiratory fitness and muscle strength benefits, adults with SCI should engage in at least 20 minutes of moderate to vigorous intensity aerobic exercise 2 times per week and strength training exercises 2 times per week. The cardiometabolic health guideline was a new guideline. And that guideline stipulates that for cardiometabolic health benefits, adults with SCI are suggested to engage in at least 30 minutes of moderate to vigorous intensity aerobic exercise 3 times per week. Now, we were very clear that these guidelines are scientific guidelines, meaning that they're derived entirely from the scientific evidence. It's what the scientific evidence suggests. And unfortunately, as scientists, what sometimes comes out of the evidence is not necessarily clear or implementable in community or clinical practice. So we were quite clear when we published the guidelines that the next step was to engage in knowledge translation efforts to take those guidelines and language them and format them in a way that would be appropriate for use in clinical and community practice. So since then, scientists, clinicians from around the world have taken the guidelines and translated them into, I think we're up to almost 15 languages right now for the scientific guidelines. And at the same time, several teams have also worked on the knowledge translation. So in Canada, you can see in the middle there at the bottom, that's the Canadian knowledge translation version of the guidelines where we've blended them together. Next to that is something that the Dutch have done. They chose just to focus on the fitness guideline. And there's a group in the US being led by Kimberly Mondin, who's working on a US translation, and also a group in Spain are working on translations as well. So the second theme that came from our meta-analysis is that people said effective interventions provided them with training on the behavioral techniques to manage physical activity. So techniques like self-monitoring, problem-solving, goal setting. So Jasmine Ma was now a faculty member at UBC, a former PhD student of mine. We conducted a meta-analysis to try and figure out which behavior change techniques are the most effective in physical activity interventions for people with disabilities. There are almost 100 different behavior change techniques that can be applied. This is based on Susan Mickey's taxonomy. And we had 24 randomized controlled trials. We found that about 40 of the techniques had been used in previous research. And what we did was we calculated the effect size for the change in physical activity behavior in a study that used a particular technique versus a study that did not use a particular technique. So of the 40 techniques that had been used in the trials, there were 5 of them that produced significant differences. So what we found was that teaching people to self-monitor, so that means keeping track of your exercise, whether it's, you know, a Fitbit or a calendar. So self-monitoring, giving people feedback on their behavior. How are you doing? Are you increasing? Are you decreasing your behavior? Instructing people on how to do physical activity and teaching people how to solve problems to overcome barriers to physical activity. Interventions that use those techniques all produced greater increases in physical activity than interventions that did not use those techniques. Now, interestingly, monitoring by others, when that technique was used, people actually ended up doing less behavior than when the technique was used. Now, this is an important one because this is something that as scientists we often do. We give people an accelerometer or some type of tracking device, but they can't actually see how they're doing, if they're increasing or decreasing their behavior. People find that really frustrating if we don't give them any feedback. If you use that, you might actually find people are getting less active rather than more active. So don't use that one. The third thing we found was that effective interventions provided social support from health and fitness professionals. And I think this quote sums that point up nicely. Having a person who can actually give recommendations on fitness activities with the knowledge of spinal cord injury is very helpful and not easy to come by in the gyms or anywhere else where people have any clue or can give advice. So that leads me to our second recommendation for evidence-based best practices with regards to who should deliver physical activity interventions, physical activity enhancing interventions. So people with spinal cord injury have reported in several studies that they want to get physical activity information from their healthcare providers. And I say that with a very liberal definition of healthcare providers, PTs, OTs, GPs, recreation therapists, you name it. Their healthcare provider, people with SCI see these individuals as being reliable and important sources of physical activity information. People with SCI also want to get information from their peers. And I think this quote reflects that nicely. Other people that have done the activity and can tell you from a person that's disabled and what it's like to do that activity and what it involves. I mean, I think that speaks volumes to someone with an injury to hear that. It is helpful. And frankly, in several of the studies that we've conducted, I see that the impact of peer support and peer instruction can be huge for a person with spinal cord injury to become more physically active. And I think it's actually a resource that's been underutilized both in research and in clinical and community practice. The next question is how to develop physical activity enhancing interventions. So working in the behavior change sphere for 25 years, I know that people often kind of, brush aside behavior change, no one ever changes their behavior. But I think that's becoming something of the past, that historically behavior change interventions often failed and they didn't work. And that's because the people designing and implementing the interventions were developing them based on a principle we now call is lagiat, or seemed like a good idea at the time. So with that sort of in the past, what we know now is that behavior change and physical activity behavior change in particular, it's incredibly complex. And the Medical Research Council about 25 years ago developed a framework for developing complex health interventions. And I think physical activity behavior change interventions certainly fall under the category of complex health interventions. And what's recommended is rather than just, throw some type of intervention out there and see if it works, is that we take the time to think about behavior change theory and to situate the intervention within a model or a theory that stipulates the mechanisms by which behavior change actually takes place. I'll come to that more in just a moment. The second thing is to engage the end users. So not just the people who will receive the interventions, but the people who are going to deliver them, whether that's a physiotherapist or an SCI peer. Third is to pilot test, but not just the intervention. Also, how the measures that you're going to use to evaluate the effectiveness of that intervention. From there, an RCT can take place to test the efficacy, and then and only then, if that RCT suggests that there is efficacy of the intervention, then you move on to implementation, which is a whole other ball game. And yeah, I'm a bit of a theory wonk. So I just want to point this out that in our meta-analysis, we compared the effect sizes for behavior change interventions that were versus were not based on theory. And what we found is that the theory-based interventions had an effect size that was about 4 times the size of the interventions not based on theory. So yay, theory. You might have guessed I could probably stand up here and talk all day about theories of behavior change. I won't, don't worry. But if you do want to see where behavior change theory is now with regards to all behaviors, but this is sort of the state of the art of what we use now in physical activity behavior change. This is Susan Mickey's model, the behavior change wheel. We say that Susan Mickey has pretty much created the periodic table of the elements for behavior change, specifying nearly 100 specific behavior change techniques. What this model allows us to do is it really boils down behavior change to recognizing what people's capabilities, opportunities, and motivations are to do a behavior, such as physical activity. Once you figure those out, you can align them with specific behavior change techniques and figure out how you're going to deliver them. Susan Mickey's book is great. It covers, as I mentioned, it pertains to all behaviors. If you're looking for a specific resource on how to develop an exercise behavior change intervention in the psychology of exercise, Heather Gainforth has written 2 chapters specifically on this topic, and she did her postdoc with Susan Mickey, so she's very, very well versed to write those chapters. Okay, so let me skip forward to an example of how we pulled together essentially 20 years of research and theory to develop a patient and provider co-developed behavioral physical activity intervention and to look at its effects on physical activity in people living with spinal cord injury. And I conducted this in collaboration with Jasmine Ma and Chris West, who some of you might recognize. We did use the Medical Research Council framework in blue across the top. And we began the process by conducting systematic reviews and building an evidence base that allowed us to select the most appropriate theory in which to couch this intervention. From there, we spent time speaking with almost 300 physiotherapists and people living with spinal cord injury through interviews, through a national survey. And then we brought these 2 groups together to do the tough work of developing the intervention itself. From there, we spent time thinking about how we would ultimately measure physical activity in the intervention. Those of you who try and measure physical activity in people who use wheelchairs, you know it's very tricky. So we wanted to make sure we would get our measure right. So I'm just going to sidestep for a second. So this was a study in which we had about 15 people with spinal cord injury, and we compared measures of physical activity using wrist-worn accelerometry, as well as self-report measure, the physical activity recall assessment for people with spinal cord injury, which asks people to recall every activity they've done over the previous 3 days and to classify it as a mild, moderate, or vigorous intensity activity. So this is a Bland-Altman plot, and when we plotted the accelerometer data and the self-report data, very interesting, what we see is in the bottom panel, roughly equal numbers of people reported less physical activity than what the accelerometers recorded, as reported more activity than what the accelerometers reported. So many people often think that if you're self-reporting physical activity, you're always overestimating, but what this plot shows is that people are equally likely to overestimate versus underestimate. When we looked at the overestimation and the underestimation, we found a couple of interesting patterns. We found that people tended to over-report the amount of time they spent doing activities of daily living, such as doing the dishes or cleaning the floor. I think we can all vouch for the fact that doing chores always feels like it takes much longer than it actually does. But also intermittent activities were over-reported. So activities with a lot of stops and starts, like wheelchair rugby, tennis, gardening, people overestimated how much time they spent on those. Now, accelerometry doesn't get off easy either. Accelerometry underestimated the time spent on strength training, or particularly the intensity. It can't tell if you're lifting a 1 pound weight or a 50 pound weight. And it also couldn't detect if a person was wheeling up an incline. We had an interesting situation. This is our beautiful I-Cord building in Vancouver. And the colored panels that you see, that's a 200-meter ramp at a 5% incline that goes from the first floor to the third floor. And it's an excellent track for getting a workout, either walking or wheeling. And when we were doing this study, we had one participant who was trying to raise money for a charity by wheeling up and down the ramp 100 times. So he was actually the most active person in our sample, and the wrist-worn accelerometers did not detect any of that activity whatsoever. So he looked like the least active person. So all that to say is that what I'd recommend is that if you are doing studies and measuring physical activity in people with SCI, you should be using both a validated self-report and accelerometry, because they're both getting at different aspects of physical activity. All right, so all of that development phase, it took us almost 2 years before we actually had our prototype of the intervention. And our intervention was designed to be delivered by physiotherapists to people living with SCI. It's called the Proactive SCI Toolkit. It's actually a 50-page manual. It's available on our website, but I'll just boil it down to our one-page cheat sheet. So in a nutshell, what the intervention involves is the physiotherapist or the interventionist sitting down with the person to try and gauge those perceived capabilities, person's opportunities, and what their motivations are to be physically active. With that information, step 2 is to develop an exercise prescription based on the SCI exercise guidelines. And then step 3 is the real work, where this involves the interventionist educating the person on what behavior change techniques are appropriate to use, how to be physically active. They link and refer the client to resources in their community to support their physical activity. And then the third piece is a tailored exercise prescription for that person based on their capabilities, their strength, their fitness, and so on, based around the guidelines. We designed the intervention to be delivered with a 1-hour intake session and then up to a 15-minute phone call or a Zoom counseling session thereafter. We did a small RCT to make sure that when physiotherapists were trained on the intervention, that they did actually feel more confident and have the skills to deliver it. And then finally, we conducted our RCT. So this was an RCT conducted at ICORD with 30 people with SCI. We had an intervention on a waitlist control group, and it was an 8-week intervention. So 1 baseline session and then 8 15-minute follow-up sessions after that. The theoretical basis for intervention is Schwarzer's health action process approach model. These psychosocial constructs are mechanisms by which an intervention is proposed to actually change behavior. Like, behavior change doesn't happen magically. It has to go through these processes. And what we found in our intervention group compared to the control group is that after 8 weeks, the treatment condition reported significantly greater increases in their self-efficacy, that is, their self-confidence to be physically active, in the amount of social support they perceived they had to be physically active, and importantly, in their use of those very, very important behavior change techniques I mentioned earlier. So that was good news. We changed those mechanisms. We were expecting good things when we looked at physical activity itself. And indeed, we found for both self-reported physical activity and accelerometry measured physical activity, we had significant increases in both in the intervention group relative to the control group. We were also pleased to see that those increases in physical activity did translate into improvements in VO2 peak, so increases in cardiorespiratory fitness. This study was the largest, this study produced the largest effects of any physical activity behavioral intervention thus far involving people with disabilities. And it was the first spinal cord injury behavioral intervention to show significant effects on fitness. And I emphasize that, many studies bring people into a center and have them train, and lots of studies have shown improvements in fitness, but this was the first to do it simply through a behavioral coaching intervention. We also found that these effects were sustained at a 6-month follow-up. So given the success of this intervention, we really wanted to take some time to sit back and figure out what was it that made it so effective so that we could replicate this in the future. I think it boils down to the intervention being theory and evidence-based. We developed it in partnership with over 300 end users to make sure it would be truly meaningful to the people who were delivering and receiving the intervention. I also think that it also really boils down to making the intervention tailored and responsive to participants' varying exercise barriers, needs, and motives. As interventionists, I think that we often underestimate or we don't appreciate the extent of the barriers that people with SCI face, let alone how changeable they are over time as a person first tries to start an exercise program and then tries to maintain it over time. Those are two very different behaviors. And we looked at this a little more closely. COVID gave us the luxury of time to dig into every bit of data we'd collected over the years. And we'd recorded the counseling sessions from that RCT. So the sessions between the interventionist and the person living with SCI. We went into those recordings and we pulled out every time a person mentioned a barrier that they were facing to physical activity. And we tracked the number of barriers over coaching sessions. So the y-axis is number of barriers, x-axis is coaching sessions. And then we also coded them according to the social ecological model, which you see on the right. Different colors mean different levels of the model. So it's kind of a messy graph, but I think the picture it paints is that the barriers do come down over time, particularly the barriers within a person, but they also fluctuate. I often wonder if people get more confident to exercise, and if they go out into the community, suddenly they're facing a different set of barriers. And these data suggest that with the ups and downs of community barriers experienced. Being able to develop an intervention that can go in and target and tailor the specific barriers that are experienced week over week, I think is a great advantage. I often get asked, okay, great. So how do I do all this? You've got a 50-page manual. It sounds like a lot. And it is, but Femke Hoekstra is a postdoctoral fellow working with me. She's funded by a Craig Nielsen Foundation fellowship, and she's just about ready to launch her spinal cord injury physical activity counseling website. This is a project she's been working on for 2 years with scientists from the US, from Canada, and from the Netherlands, scientists who have been involved in physical activity counseling, as well as practitioners themselves. And what she's done is really keyed into physical activity counseling being about building rapport, identifying those capabilities, opportunities, and motivations, what to say, what not to say during the conversation. She's developed a flow chart that streamlines counseling into engaging, focusing, and evoking, and planning. And do I have it up here? No, I don't. So the website will be going live soon. If you'd like to reach out to me, I can give you that information on the website. And what she has on there, she's developed training programs, videos, tailored modules to train people on how to deliver the counseling. Femke is an extraordinary implementation scientist, so very meticulous, and she's been doing a lot of piloting with people who will use and receive the counseling. So we're excited to be finally on the verge of being able to share that. Just want to finish up by telling you a couple ways that we've now moved forward from that trial and how we're using the counseling. So this is also a project that's led by Jasmine Ma, and this is the clinical implementation of the proactive SCI intervention. So working in collaboration with physiotherapists at GF Strong Hospital and with Spinal Cord Injury BC, who runs an extraordinary peer support program, what we've done is we've gone to worked with inpatient physiotherapists at GF Strong and community-based SCI peers and trained them to do the physical activity counseling. The whole idea with this project was to see if we could try and stem that precipitous drop in physical activity that we typically see when newly injured people with SCI are discharged from inpatient rehab back to their communities. So the idea is that the physiotherapist meets with the patient and begins the conversation while they're still inpatients about physical activity. And if the patient is ready, then they receive an exercise prescription and that first physical activity counseling session. When the patient is ready for discharge, if they would like, the physiotherapist refers them to a spinal cord injury peer in the community, and this is a paid position where we've trained 2 peers to provide up to 10 physical activity counseling sessions post-discharge. So we've recruited 28 participants during COVID into this study. It was supposed to be controlled, but it was COVID, so we were down to a pre-post study. We're just collecting the final 6-month data, but the results are extremely promising. We're seeing that 3 months post-discharge and even up to 6 months post-discharge, not only are people maintaining, they're actually increasing their physical activity. And they're also achieving physical activity at the levels recommended by the SCI exercise guidelines. The other trial we have underway right now is a pragmatic RCT, where I'm testing the effects of the guidelines on the primary outcome of SCI chronic pain, but we are actually measuring a wide range of fitness and mental health outcomes. So in this study, participants are randomly allocated to experimental or a 6-month waitlist control condition. They're given an exercise prescription based on the SCI exercise guidelines. This is the Canadian Knowledge Translated version. A trained fitness professional goes to their home or to the gym, wherever they would like to work out in their communities, and shows them how to do the exercises according to their personalized exercise prescription. Once a week for the entire intervention, they receive a phone call, 15 minutes per week, to provide that ongoing counseling support. And we also have a small research gym in our facility, so some people can come and work out there if they'd like. And we're doing measures at 0, 3, and 6 months. I'm running this trial in Kelowna and also at ICORD. We opened recruitment January 2020 and closed it March 2020, unfortunately, but we've almost got 30 participants enrolled, and our target, we need 60 to be adequately powered. I was hoping for 72 initially, but we'll see how it goes. And just to wrap up with some closing thoughts. I sometimes think that there can be this perception that in developing physical activity interventions for people with SCI, it's something nice to do. It's a nice thing to do off the side of your desk. But physical activity for people living with disabilities, it's not a charitable act. It's a human rights issue. There are several policies, international policies and action plans in place that reinforce physical activity for people with disabilities, but these policies are not sufficiently enforced, and they're not sufficiently resourced to actually have teeth. I think that physical activity for people living with SCI and other disabilities is an issue that demands better evidence, better practice, respect, and value. As part of the Lancet paper, I actually went through almost 27,000 abstracts of all of the papers published in the world's top 5 medical journals over a 20-year period. I found that only 1% of those papers addressed anything to do with the health of people living with disabilities. Of those, 0.001% addressed physical activity in people living with disabilities. And how many do you think specifically focused on people with spinal cord injury? Yeah. So with that in mind, I think it's time to end those exclusionary scientific practices that keep people with SCI and other disabilities out of large population epidemiological databases. We need to collect those data from children, youth, and adults with SCI and other disabilities. We need to adequately resource the policies, research and implementation to advance the fundamental rights of people with SCI to fully participate in physical activity. And I think it's time we meaningfully engage people with SCI as equal partners in physical activity research and intervention design. And with that, I'd like to acknowledge my awesome lab back home in Kelowna, the community partners that we work so closely with and just make this research so much better, and our funders. And I'll leave you with my contact information, and I'd be happy to answer any questions. Thank you very much.
Any questions? Not, I'll start. So physical activity is a broad construct. You talked a lot about cardiorespiratory and strength, never mentioned anaerobic power, okay, which is critical.
Yeah.
Probably more in your neck of the woods than ours because of hills, but we have pavers and high pile carpeting. And there's evidence that it changes levels of independence, of being able to utilize that anaerobic power, which is not endurance and it's not strength. So other than we've reported power and the importance of it, do you know of anyone else who's done this and has actually done testing, with 30-second, testing of upper extremity anaerobic power that was actually validated in our labs?
Yeah, so when we developed, great question. When we developed this SCI exercise guidelines, the systematic review that underpins those guidelines did have a few studies. I know certainly from your work, your studies were in there, but I'd say there may be a handful of other studies that had measured power output, but not enough. And we lumped it all together under cardiorespiratory fitness because there just weren't enough to section it out. In the work that we do, that's one of the things we're struggling with, is we recognize how important that is. But I actually think that we need to develop better tests as well of functional power output to be able to demonstrate to people in a meaningful way that if you exercise, this is how you're going to see improvements in ADLs and your ability to get out. I was about to say out and about. Sounds very Canadian. Your ability to move around. But yeah, I think it's not something that we have paid enough attention to, and I think it has important implications for ADL, and in some cases more than the VO2 max test, as you alluded to. Yeah.
I really don't have a question, but I just wanted to make a comment. I think that your approach to this is something that should be modeled by more clinical researchers and we all know that like eating right and exercising cures everything, but nobody does what they're supposed to do. And so I think that the implementation where, you have really used the theory and then, all the end users to actually figure out how do we get people to do this, including ourselves, and stick with it. I think it's just wonderful to hear about this research. So thank you. Thank you very much.
It's very kind. Thank you very much.
Hello, thanks for your talk. I study cells and dishes. And I'm curious what the barriers are for you to do well-powered studies on the effect of exercise on lifelong changes in people with spinal cord injury.
Yeah, thank you for asking, because I get asked that a lot when I submit to journals. Why isn't this adequately powered? So the many barriers that you saw for people to be physically active are many of the same barriers we experience when people are in our trials. The number one being transportation. So just getting a person with an SCI to the lab to exercise multiple times per week, or even if it's just to collect blood, like that's a huge that transportation is a huge barrier. People with SCI are susceptible to infections, bladder infections, pressure sores, and that can derail an exercise program. And depending on the inclusion/exclusion criteria, it can knock them out of the trial completely, or trying to bring them back into the trial can be challenging to get them back up to where they were before the trial ends. Those are the two of the biggest challenges we face, let alone just the myriad day-to-day challenges of getting a person to an exercise facility, beyond the transportation. I mean, people with SCI, we know many cases living very challenging lives. And I know that people are trying to arrange bowel and bladder care in the morning to work around the times to come into the lab can be complicated as well. So there's a long list of challenges, but those would probably be the biggest two: the transportation, the adherence, and recruitment. Like ultimately, we are dealing with a relatively small population. You add in inclusion criteria, being active at a certain level or being within a certain age, your pool of participants gets smaller and smaller and smaller, and then add in non-adherence and dropouts, and you're working with a very tiny segment.
We have the great opportunity here with two women with lived experience. And one was Rachel Cowan, who did her postdoc here, and the other was Kim Anderson.
Yeah.
Okay, and we published on this, but there was this constant reminder that physical activity across the spectrum of its attributes would be critical for simple things like getting to the garage.
Yeah.
And, Rachel used to comment on the number of ways she used to have to go places just to not give up. Okay, and to completely eliminate essentially what is guarded more than anything by people with spinal cord injury, that's independence. Okay, it took away her independence. So why she moved to UAB with all its hills and there, I don't know, but that's something, and we're at the threshold of doing this right now. So you being here and presenting this is very timely. Okay, we're now in a rehabilitation center you've seen for the first time today, in which we can start doing this with inpatients.
Right.
And we've been working with recreational therapy, okay, to start bringing people down and letting us in-service them as to opportunities for this. Some of, certainly not as comprehensive as what you're doing and showed, but here's what you can do to help yourself. We've looked at, and we've done it with the Karolinska recreational activities. Okay, if you want to, and it's almost like an Ainsworth compendium thing.
Right.
If you want to kayak on the Stockholm waterway, okay, here's a level of endurance that you need, and we will train you, okay, to achieve that, so that you can, your physical activity is more than health behavior; it's life enjoyment.
Great.
Well said. I'm sorry you didn't have the microphone, so no one heard it, but that's okay. Loved your presentation. Thank you very much. So exercise is good. I exercise. Many people exercise. So maybe I missed it. What are your outcome measures to evaluate whether quality of life is being improved by the exercise paradigms that you're establishing so well?
Yeah, great you asked. I didn't show any quality of life data. Raises an important issue. I think a lot of time is spent looking at the effects of exercise on quality of life. And that's another one of those black box issues, that if exercise is going to improve your quality of life, you need to be measuring quality of life outcomes that a person really values. So is it their physical aspects of their quality of life, mental health aspects of quality of life? Looking at the data, I don't think exercise improves global life satisfaction. I think your life isn't suddenly going to be overall better at that level, but it can improve specific aspects of quality of life. We've tended not to measure quality of life just because I get frustrated by it being, misconstrued as this global construct, and you often don't see specific outcomes. So we measure things at a smaller level, look at psychological well-being, and we do see improvements in affect. So the balance of positive moods versus negative moods. We'll see improvements in self-efficacy, so physical self-confidence, how people feel about their bodies, perceptions of physical functioning, but we tend not to measure, global quality of life outcomes, just because you tend not to see anything. It doesn't happen at that global level. The changes are a more proximal level. I hope I answered your question.
Great. And any changes in sex in terms of male-female responses?
Unfortunately, we never have enough women in our trials to, But in Canada now, you can't get a grant without saying that you'll disaggregate your data based on sex and or gender. And you have to make a rationale. If you want a federal grant, you have to explain why you're not going to recruit equal numbers of men and women. So we've explained why in the SCI population, but I will disaggregate the data. No matter how many women we end up with in this trial, the data will be disaggregated. So at least we'll start being able to have some means and standard deviations for women.
Great talk.
Thanks.
You mentioned some of the accelerometer data, and I was wondering if you have a list of wearables, ECG, blood pressure, galvanic skin response, anything that you're excited about that can maybe measure exertion better. There's trade-offs with every sensor, but I was wondering if you can speak on that a little bit.
I get excited about a lot of the devices that come out, and then quickly my expectations were diminished. Like the Apple Watch, I knew that Apple was trying to come up with an algorithm to measure wheelchair pushes, and so excited about that 5 or 6 years ago. And we know where that landed. So Tom Nightingale has written a nice paper where he's laid out the pros and cons of all the device-based measures and the self-report measures. So I think if you're looking for something about where things are now, the Nightingale et al. Paper is a nice description. Yeah, unfortunately, I don't see anything practical coming out anytime soon. And for me, practical is key because I do so much community-based work. Most of my studies, I tend to go out in the community rather than bring people to me. So I need a device that I can send to people that they can easily attach or wear. And unfortunately, I don't. Do you know of anything?
I don't know why you would ask me. I don't know the wearable space as well, but
Okay.
we do that. We'll talk later in the lab.
Okay.
Yeah. so
Okay, that'd be great.
I'd love to pick your brain.
Yeah,
Thanks.
likewise.
Our Zoom listeners, do we have any questions? Oh, we have one right here. Stand by.
Thank you. That was a really great talk. I'm kind of interested in how you, in the comparisons between able-bodied and people with spinal cord injury. When you talk about exercise and you say vigorous exercise, there's obvious differences between the two groups with
Yeah.
respect to how much physiologically is being accomplished, I
Yeah.
guess. And I'm just wondering how it's defined, and do people with spinal cord injury have to actually work harder in order to achieve the same gain as a person with that is not injured?
Yeah, these are $1 million questions. So the first one's easy, the second one's hard. So moderate to vigorous intensity has specific meanings based on the percent of maximum heart rate achieved or percent of maximal volume of oxygen consumed. And they're the same for all populations. So you're looking at, I don't know, between like 60 to 80% of your maximal heart rate. So that's consistent. But where things get tricky is asking people to self-report their moderate to vigorous intensity activity. And we've been telling the general population to do that for years based on perception, based on talk tests, based on ratings of perceived exertion. What we're starting to see, though, is that people aren't as good as that, are not very as good at that as we thought. So there's starting to be awareness as to whether people really are exercising at moderate to vigorous intensity as prescribed. And people with SCI, particularly tetraplegics, it's really difficult to perceptually declare whether it's moderate to vigorous intensity. So on that side, it's not quite clear yet. We know both able-bodied and people with SCI have challenges discerning between moderate and vigorous intensity activity, but we do have physiological parameters that we can objectively discern if they're working at those levels. Your second question was about whether people with SCI need to do more. So that's when it comes to the guidelines, I think one of the things that concerns me is that with tetraplegics, and correct me if I'm wrong, Mark, but I'm not even sure that many tetraplegics can exercise intense enough, long enough to derive cardiometabolic health benefits, that if that is possible. So we also know that propelling a wheelchair requires more exertion than ambulating. Chris West and I have tried to do this, tried to take the 150-minute guidelines and put it in SCI equivalents, and it becomes super challenging also because of the heterogeneity of people's function and physiological function after the injury. So that was just like a whole big word blob. Bottom line is, we don't know. It's tricky, and trying to draw comparisons, specifically trying to say that what able-bodied people should do versus what people with SCI should do is the same. I think that's where things completely fall apart.
I had just one other question. I was kind of curious about when people are being monitored, they're actually performing, is that poorer or less or something that you mentioned? You had it on one of your slides.
Right. If you give
Why is that?
So if you give people an accelerometer device and you tell them, go wear it, you're part of a study, but you don't tell them how they were doing, they actually do less. Now, if you give them an accelerometer bang, right away, they're going to do more because they can suddenly see how much they do and they increase their activity. But if you don't tell them, I think they lose motivation. They think, why do you, the scientists, get to know and I don't? No one is specifically asked, but I think that's the reasons why people get less active. But certainly give someone a thing that they can read and monitor, they will get more active.
Couple in the chat. While we wait for the chat, the use of the board range model, ratings of perceived exertion does not fit spinal cord injured.
Yeah.
Who have dislinear relationship.
That's right.
Between heart rate responses throughout the submaximal exercise range and actual oxygen consumption. We published that, and yet people continue to use RPE, which is, I guess, fine for field-based measures, okay, but not for research.
Absolutely. It's a nice review done by Vicky Goosey Tollfree's group. If you train people with SCI how to use the RPE scale, it gets better. But I think that's true for anybody without an SCI. I think anyone just using it for the first time, people don't know how to rate.
Oh, yeah. So I was just, I didn't type.
Hi. Says, have you looked at monitoring heart rate via a watch to see how long they are in their moderate to high intensity zone once established by a submax or max test?
No, I haven't. No.
It's a study for you to do. Now that you've mentioned it.
Really good talk. My question is regarding in the data that you've collected, have you ever looked at socioeconomic status and the outcomes with behavior? And the reason I ask that is because a lot of the non-SCI literature, a lot of those participants are typically fluent. And I would beg to argue that in SCI, it's more mixed. And I've been in Pennsylvania, Miami, San Francisco, and across all those regions, I see the same type of mixed pool of participants participating in research. And I'm wondering if, socioeconomic status has any kind of impact on some of the outcomes you're reporting.
Yeah, great question. So short answer is no, we haven't looked at that. And that's probably a reflection that in Canada, our pool is a little bit more homogeneous, I think, in terms of SES, just the way our social support, our social network is constructed, disability supports and so on. So tend to be relatively homogeneous. Where things become discrepant is whether people have private insurance after, say, an automobile accident, that's the cause of spinal cord injury. And if they don't, say if it was a diving accident in their backyard pool. So for that, we do sometimes see differences in physical activity behavior, but in my trials, I haven't had the statistical power to parse out different SES categories and look at that. But that's a great question. Thank you. Thank you very much.